So yeah, I mean, now we get to the easy stuff, which is really just talking about the liver, liver enzymes. And what I really want to focus on is a good primary care approach. What are you guys going to see in the office? How are you going to approach that? Obviously, you don't expect anybody from the primary care to be ordering a lot of zebra tests, etc. What are you going to do with the patients you typically see? So I would like to start off just with some of the take-home messages, because after a few minutes, people tend to drift off anyways. So we'll hit the, what I want you to take from all this is that, first of all, liver enzymes are not really function tests. Liver enzymes is just much easier to say. When we talk about function of how the liver really is functioning, we're talking about things like what's the albumin, how's the INR, what's the bilirubin. These are things that the liver actually does. If your liver is not functioning well, the better way to explain to the patients is if your liver enzymes, and I'll keep using that term even though I don't necessarily like it, when they're elevated, your liver just has a headache, and that's okay. Everybody gets a headache. But when it's not going to work, calling in sick, that's when your liver is not working. That's when we talk about these true liver function tests. So the patient with liver, elevated liver enzymes typically will have normal liver function. The better term is probably liver-associated enzymes. But again, it's just longer just to say. So what are transaminases? So now we're just talking about ALT, AST, and primarily ALT. That's the one that brings everybody's sphincter tone a little bit higher than the other numbers. This is particularly high in the liver. You can find it in other places, but it's a cytosolic enzyme. When there's damage to a hepatocyte, a liver cell, it breaks open. ALT is released. That's where you're measuring it from. Again, you can find it in other places, but it's primarily found in the liver. So it is an indicator of injury. Now, the height of elevation does not necessarily correlate with the severity of disease, so you have to be careful. Sometimes, a lot of patients, they want to know, well, if my ALT is 200, that must mean things are really going bad. Oh, it's only 100, that must mean it's better. That doesn't really correlate. And liver enzymes are also elevated in even just about 3% of the population that are healthy. It's just a number, and obviously people not everybody's going to fall into the what's quote unquote a norm across the U.S. So what is a normal ALT? To be honest, actually, we probably don't really know. Normal values can vary depending on what labs you use, what geography of where you are in the United States. There's a normal range that can go anywhere from 30 to 72, and there's changes even with BMI. And this is probably why we are seeing more slight increases in baseline ALT levels because of, as you'll hear later with Dr. Whitaker and NASH, with obesity and NASH, you are going to get a little bit of a tendency to have a higher ALT. In males and females, this is probably the numbers we should be using. And these are much lower. So males should really be less than 30 and females less than 19. So if we look at some NHANES, what is the prevalence of abnormal liver enzymes? So if we use the cutoffs 37 and 40, these are patients with no hepatitis C, no alcohol. About overall, 8% are going to have elevated or abnormal liver enzymes. So there's a baseline elevation in liver enzymes that you will see across your patient's population. And again, a lot of that goes back to BMI. Is it a sensitive marker of liver disease? I kind of already told you that it wasn't. Historically, you can see changes with hepatitis C, viremia, but again, sensitivity and specificity are not very good. So you can't use that as a marker for how bad the liver is actually functioning, certainly. And what about detection of is there fibrosis or cirrhosis? No, you can't. Even though the biggest mistake is that with patients with actually frank cirrhosis and advanced liver disease may have liver enzymes that are normal, mostly because they don't have any more hepatocytes to be destroyed, and you're not going to find that elevated AST or ALT. So if we put it into perspective, we probably don't know what the normal level is, but we do know that we are underestimating, and what might be considered normal, high normal on our lab values probably is actually on the edge of being an abnormal test. It does lack any sensitivity specifically for how bad somebody's liver disease necessarily is. And again, you will see elevations even in normal people. So I'm just going to talk about a case, and we'll use this and really go through, hopefully, the typical patients that you will see in a primary care setting. 52-year-old female, moved new to the areas looking for somebody new, a little hypertension, some obesity, fibromyalgia. She's gained some weight over the last year, does have some arthralgias, some myalgias. There's no history of liver disease, says she does not drink any alcohol, but her prior physician had concern about maybe she had lupus. So this is just sort of a nightmare patient. But this is about every patient, with a lot of the new patients that you see. Just at a hodgepodge, who knows? She could be anything. But we'll find the answer at the end. Medication, some gabapentin, some Celexa, lisinopril, and some pain medicines. She probably doesn't, must not be from Florida where it's hard to get pain medicines from your primary care doc. But has to have something, I guess, for her rheumatoid or her fibromyalgia. On the exam, the BMI is 39. That's considered obese, hypertension, but otherwise no significant findings, and certainly nothing on exams to suggest chronic liver disease. So you do have you get some current labs. ALT and AST are slightly elevated. Alkalis is okay. Total bilirubin is normal. So what do you take from this? Okay, so the transaminases are up a little bit, but look, the albumin's okay. The bilirubin's okay. Headache, the liver just has a little bit of a headache. It's still working fine. Good thing is you look from a year ago, and the numbers, again, still had just some baseline small elevation in her transaminases. And there's the ANA of 1 to 160, and this is probably where maybe this lupus or whatever autoimmune problem that the prior physician was considering comes from. So what do you do? Really the first thing on any of these patients that have abnormalities, you want to look at, well, what are some common treatable liver diseases that you can diagnose and get treatment for. And really the biggest is chronic viral hepatitis. And for hepatitis B and C, those are very easy. Now, you can order, really all you need is a surface antigen for hepatitis B and an anti-hepatitis C antibody to screen for hepatitis C. That takes a few more clicks, a few more writing. So you could also just do the hepatitis panel, which is what everybody does. But you don't necessarily have to. Now the other thing, even for this patient, is that she is also in the baby boomer era. So she was born between 1945 and 1965. So she should have been screened for hepatitis C anyways. In her case, she wasn't. And then hemochromatosis is also something else to consider. So you can check some iron studies. And if we look at her results, the surface antigen was negative for hepatitis B, so there's no hepatitis B. Antibody for hep C is negative. You're done. Okay, there's no hepatitis C. And you did some iron studies. The ferritin was 650. So we know there's no viral hepatitis, but maybe this is hemochromatosis, right? It could be with the ferritin being high. It's a common disease, mostly in white population. Patients do present with mild elevations in liver enzymes, transaminases. End organ damage, you really won't start to see this, and especially in females because of menstruation, you may not see that they have any end organ damage or complaints until a little later in life. Males, you may start seeing a little sooner. What's the best screening test, though? Well, you've already done that, and that's the transferrin saturation. Really, if that's less than 45%, you're done, which in this patient was 17%. So it's not hemochromatosis by any means. So why is there elevated ferritin? Well, ferritin is really an acute phase reactant. You can find an elevated ferritin from running around the block a couple times if you get enough inflammation. So you can also do genetic testing if you feel compelled. In this patient, there really is no need to, but there is more genetic testing that's available to confirm whether somebody does have hemochromatosis. Now again, maybe this is autoimmune hepatitis. Remember there's the fibromyalgia stuff, the arthralgia, all the other allergies, and the ANA that was positive. Why is that important? Because again, it's something that's treatable and can be fatal, especially if you have Somebody with chronic liver disease, maybe they didn't know. Certainly somebody that already has some liver damage, some fibrosis, and then they have a flare in autoimmune hepatitis, those are the patients that can be fatal and they can have liver failure. Now, typically these patients will present with very high liver enzymes, much higher than what this. Usually you'll see these in the 500 to higher range. And you'll also see the elevation in IgG levels in proteins. Bilirubin increase is also common. Autoimmune markers are fairly good. ANA is positive, even in our patient it was positive. And there's also F-actins, which are a little bit better than this patient happened to be negative. You can do liver biopsies in cases, and that will also help. There are specific histologic features that you can see on liver biopsy to help if you're not sure about the diagnosis. This patient did have a normal IgG, and F-actin was negative. This is not autoimmune hepatitis by any means. So, what about alcohol? Patient doesn't drink, but patients always lie, so you don't know. She probably may drink like a fish. But we'll assume that she doesn't. But I would always keep that in there because anybody with abnormal liver enzymes can be just a closet alcoholic. But that being said, a lot of people, one misconception is that there are a lot of closet alcoholics who don't have any abnormal liver problems, and so not just because you drink doesn't mean you're necessarily going to have problems with your liver. I don't tell my patients that. Just drink more, but don't make that assumption. Typically, as you know, there is you'll see the AST to ALT ratio, but again, you can also be fooled by that because if the patient has a more advanced disease and fibrosis, that ratio will actually reverse. How do we diagnose whether it's alcohol? Well, again, that's where it's a patient relationship, and if they're telling you they don't drink and you really don't believe that they're drinking, they don't have other things like macrocytic indices on their white count, then this is a diagnosis of exclusion at that point. What about celiac? Everybody likes celiac. I hate celiac. I think because I've only diagnosed literally one patient with celiac. By the time they come to me, either the patient's already Googled and they think that's what it is, and then they're right, and so I didn't get the diagnosis, or somebody else already has. So, but it is common. So they say 1% of the population. It is a common reason for elevated liver enzymes, though, and it should be part of something to consider in patients who have some baseline, even mild elevations in their liver enzymes, particularly if they have other symptoms that may be consistent with celiac. Again, so up to 9% of patients with unexplained liver enzymes could be from celiac. How do we test for that? Really, the best test is a serology test, and we look for TTG IgA antibodies. Now, some patients are also deficient, or they have very low IgA antibodies, so you should also order a total just to make sure this test is correct. And you can also do really a gold standard, which is go in and get tissue from endoscopy, looking in the small bowel for a diagnosis, and also you can classify maybe how bad the celiac is. I believe we're talking about celiac later. What about medications? It's patient is on Neurontin, some Celexa, some lisinopril, a little bit of pain medicines, and who knows? No herbals, so they say, but you really have to hammer that a lot. It's literally, you'll have patients in the hospital with transaminases that are 1,000, and they swear they haven't had anything. And it's not until you get a liver biopsy, and then they say, "Oh yeah, I took that liver cleanse stuff." I don't. So, you just always have to think about medications. Although I wouldn't jump to that as an initial reason. Now, the other thing about medications is that a lot of times medications are only really going to cause problems with the liver if they have other chronic liver disease. So in general, medications are safe with patients. There are some that are particularly hepatotoxic, but again, that's when they have other chronic liver diseases in conjunction. What do we think about as far as seeing patients, and do we think are we worried that it's a medication? What do we do? Because with statins, etc. If it's a increase in liver enzymes, but less than 3 times, we generally will just follow those patients. We don't necessarily stop their medications, but again, now as a primary care, you can, if you are concerned that it's from a certain medication, and you can opt to change that or stop that and see how the transaminases respond, that's more than appropriate. But certainly, if the numbers are greater than 3 times the upper limits of normal and greater than 5 times the upper limit of normal, I would certainly stop the medications until you can figure this out. And then they have what is called a Hy's law. So these are patients that are really in trouble. You've given them a medication that has significantly high ALT, but also the bilirubin. So the ALT is high. It's a very bad headache. Probably had a migraine by now, and they're also sick and not going to work because their bilirubin's high. These are patients who can really be in trouble, and these are typically these are ones who've been exposed to medicine as truly a drug-related liver injury. And at any time, in the primary care setting, if you have concerns about the patient, you don't have to feel like a cowboy. You can pick up the phone and call Dr. Peterson 24/7. He'll get them in, and we'll put a pacer on the liver if we need to. So the take-home message from as far as with medications, it is still safe to prescribe medications, even though they may have some changes in liver enzymes. One of the biggest things I see is, I have cirrhosis, believe it or not. Okay, so if a patient has cirrhosis, that doesn't mean they cannot have acetaminophen. We try to limit that. We shouldn't be more than 2,000 grams a day, but they can still take Tylenol. The bigger thing is that they have a good appetite and that they have the right nutrition, that they can metabolize the breakdown products of Tylenol. But if they stay to 2,000 milligrams, even a cirrhotic, they're fine. In fact, sometimes acetaminophen might be better than non-steroidals in patients who have cirrhosis. So you can be on medications even though your liver enzymes may not be completely normal. So what's wrong with our patient? We've looked for the chronic viral hepatitis. So it's not hepatitis C, it's not hepatitis B, it's not hemochromatosis, it's not autoimmune, it's not medications. So the patient actually has fatty liver, which is, at the end of the day, the most common reason we're going to see patients who have abnormal liver enzymes. It's really the hepatic manifestation of metabolic syndrome, obesity, hypertension, the triglycerides are elevated, low HDL, fasting glucose greater than 100. Dr. Whitaker is going to talk about this more, so I won't steal any of his thunder. But that fasting glucose really is one of the markers we kind of look for because your lab sheets, they come back and then their sugar is 105. And is it flagged? It's okay. You don't have diabetes, right? So because that doesn't meet criteria for diabetes. But that can be very early indicators that there's insulin resistance and there's problems that are going on, especially for metabolic syndrome. So again, just a general approach. Look for these common problems: viral, hemochromatosis, alcohol. Consider some other things: celiac, autoimmune medications. Look for features of metabolic syndrome. Don't be afraid to refer the patients out if they have abnormal liver enzymes, at least to have a one-time look. What will we look for? We can look for some of the more fancy things. We can look for PBC. We can look for overlap syndromes, so these are patients that they have a little bit of primary biliary cholangitis and you have a little bit of autoimmune hepatitis, a little bit of each. We can look for Wilson's, alpha-1 antitrypsin. We can look for occult hepatitis B that maybe is not being picked up. There's seronegative autoimmune hepatitis, and again, even with non-alcoholic fatty liver disease. So we can sort of rule out all these other things that if we're not getting anywhere. A final note. Now, what about? I mentioned because this is another thing that often comes up. What about patients who come in with elevated alkaline phosphatase, and that's the only thing that's elevated? They shouldn't be ignored. Now, alk-phos is not always from the liver, and you can fractionate that. Sometimes it's from the bone. But if it is truly from the liver, there are things that we would look at from a more GI point for obstruction. There could be mass lesions. There could be more infiltrative lesions. Renal cell carcinoma can present like this. Again, it still could be medication toxicity or PBC. So some take-home points again: liver enzymes are important markers of dysfunction. If we're talking about INR, we're talking about bilirubin, we're talking about albumin. ALT is more of a marker that your liver just doesn't feel good. Every patient, if they have abnormal ALT and transaminases, they probably should have at least one look at by a hepatologist. The one thing you don't want is, because again, these numbers go up and down, they fluctuate. What you don't want is a patient who this has been going on, particularly fatty liver, it's been going on for several years, and now they're actually cirrhotic, and no one really knew. We didn't know. Now we know because they're coming in with ascites or a hepatocellular cancer. Again, there is month-to-month variation, and that's it. That's just a general kind of a